Hi, I'm Claire Murphy. This is Well. Australian women, welcome to your full body health check. We are now 3 episodes into Well, and we have found out so many amazing things about women's bodies. And today we're going to find out even more.
And I'm Dr. Mariam, a GP and a passionate advocate for women's health.
Now, PCOS, PCOS, polycystic ovarian syndrome, whatever you would like to call it, that's what we are actually going to be focusing in on today. We are also again going to head off to the quick consult room. This is where you can have any question you want to ask about any particular health condition. We will do our best to answer it with as much information as we can get for you. And today, Brianna is asking about a problem that she experienced using a medication to not get pregnant, only to be told her weight might make it quite ineffectual. But first, let me share with you some fun facts that I found out about the human female body this week. Let's go to med school.
Welcome to med school.
So, Mariam,
Yep.
today
Yep.
I have 3 fun vagina facts to share with you.
Let's do it.
I thought we'd run out of vagina facts, but apparently it is a limitless topic, vaginas. I read that the tissue that lines your vagina is the same or at least similar to what's lining the inside of your mouth.
So they do closely resemble one another. So they're both composed of something called stratified squamous epithelium, which are multiple layers of cells on top of each other. And this makes them mucous membranes. And they serve both similar functions. They act as a protective barrier and facilitate lubrication.
All right, fun fact number 2. As you know, like sometimes when you have your period, it's referred to as Shark Week.
Yeah.
Now that is because of the blood, right?
Yeah.
But I found out that apparently vaginas actually do have something in common with sharks because we both manufacture an organic lubricant called squalene. And if I remember rightly, this is what is being marketed to me as something I'm now supposed to put on my face.
Oh, goodness.
And finally, something else I found out, and this is something that I'm weirdly fascinated in, is like the etymology of words, like where they originate, where they come from. So the word vagina, which is so good to say out loud. Vagina. It comes from the Latin word for sheath, as in like a sheath for a sword, because of course it must be all about where a man puts his dagger, right? And also, fun fact, secondary to that, the clitoris, which is named after the Greek word klitoris, which I presume that's how you pronounce it in ancient Greek.
Clitoris.
It means to shut away.
Oh, to shut away.
Now, sorry, sir.
No, we don't want to shut that away.
We will be doing the opposite of that.
Exactly. We need to be educating people where that is.
Exactly.
Yeah,
And what I love is when people first see a picture of just how big the clitoris is, because all of that fun, joking about men not being able to find it, it's actually quite ginormous.
Yeah, geez, you can't miss it.
You can't miss it, boys.
It's time for the checkup.
All right. All serious face now, because we are going to speak about a topic that is very serious and does affect quite a few people. In talking to Professor Helena Teede, who we'll be catching up with a little bit later on today, it is referred to as PCOS. Some people do call it PCOS, but she says like the standard is we refer to it as PCOS or polycystic ovarian syndrome. It is one of the most prevalent endocrine disorders affecting individuals of reproductive age. Apparently, global prevalence has got an estimate of somewhere between 10 and 13%. It impacts around 1 in 10 Australian women, which is huge. Now, Mariam, I've been seeing on social media that there are 4 types of PCOS: insulin-resistant, inflammatory, hidden cause, and pill-induced. Is that a thing?
No.
Okay.
To put it simply. So
Right.
Polycystic ovarian syndrome, it's a massive spectrum of pituitary and ovarian dysfunction. It is so unique to each individual. So, and these types of polycystic ovarian syndrome, they're not recognised by leading experts. I can appreciate there's a lot of noise on social medias and trying to put them in these little subgroups, but that's just not how it is at the moment.
Now, I feel like we're going to be doing this with a lot of things that we talk about on this show because when we talk about symptoms, they vary a lot from one person to another, right?
So I kind of group them in conditions. So like dermatologically, so we think of things like acne, hair loss, like generally around the scalp area. You have like an increase of hair growth. So you've got that chin hair growth, and there could be hair growth in other areas as well. And some people have like dark, thickened patches around their the neck or under their arms. And then we have the reproductive component. So you've got irregular menstrual cycles. Some people have difficulty trying to conceive. For some people, weight gain and difficulty losing weight is a presenting symptom. Some people, I mentioned, have irregular periods, but some people have no periods at all as well. Then there's the psychological component. So we know that people with PCOS have increased risk of anxiety, depression, eating disorders, issues with their body image, and they've got a psychosexual component added to it. And that's essentially they don't really want to engage in sexual activity, and a lot of it is thought to be due to how they're feeling about themselves.
How difficult is diagnosis for PCOS, and what do we do to narrow it down?
The diagnosis is actually quite straightforward. I think the issue is that a lot of doctors might dismiss it or just tell people, just come back, or this might be PCOS. But generally for the diagnosis of PCOS, we like to look at a criteria. And essentially as an adult, you need 2 of the 3 criteria to be diagnosed with polycystic ovarian syndrome. The first is having irregular periods. So that's periods that are less than 21 days or more than 35 days, or you're having less than 8 periods a year. The second is having elevated levels of androgens, and we can establish that clinically. So if you had those signs of the acne, the hair growth, or that hair loss at the top of your head, then we don't need to do the blood test. But if you don't have that, then we do that androgen profile and see whether you've got biochemically elevated levels. If you don't have one of those, then we go on to the third. And that's essentially you have the polycystic ovary picture on the ultrasound, or they've introduced now, which is fantastic for people that don't want to have that probe inserted into their vagina, is the AMH blood test. So as long as you have 2 of those 3 criteria, you meet the diagnosis for polycystic ovarian syndrome.
What do we do as far as treatment for PCOS?
So first line for all patients who have been diagnosed with polycystic ovarian syndrome is education. So many people get diagnosed and it's like, this is your diagnosis, see you later. And it's really unfortunate. So, and we just let them know there's, 4 domains that it can affect. It can affect your psychological health. Are you experiencing any of these symptoms of anxiety, depression, problems with your body image, etc.? We speak about the skin and the hair and the acne, and we talk about possible solutions there. We speak about the metabolic risks associated with polycystic ovarian syndrome and why seeing your doctor yearly is really important to monitor things like blood pressure. And then fourthly, the reproductive side of it. Not many people know, but there's an increased risk of endometrial cancer. It's like 2 to 6 times. And for some people, they may struggle to conceive. Not that doesn't happen for everyone with polycystic ovarian syndrome. It's not to say that you will have issues with fertility, but some will experience issues with fertility. And I think that's really powerful, even if you're young when you get that diagnosis. So it gives you time to plan ahead. And we know that your best chances are under the age of 35. If that's a possibility for you, then that's fantastic. So I think that knowledge is quite powerful. Then we move to lifestyle. Mm-hmm. And now this is a bit of a tricky one because a lot of people that get diagnosed get told to lose weight and see you later.
That's something that I've been told many times. I don't have PCOS, but it's a common thing and it's not easy, right? Especially when you have PCOS, it's actually harder to lose weight, right?
That's right. But we do know that healthy choices, increasing physical activity, changing your diet, and losing 5 to 10% of your body weight if you are overweight is beneficial for you in PCOS. It essentially reduces that insulin resistance. It helps regulate your cycles. It improves your mood. It helps with the weight loss. And when you lose that weight, it reduces that insulin resistance, and it just has this beautiful effect. But we also know that for many people with PCOS, losing weight is quite hard and they definitely need support, which is why we like linking them in with a dietitian, an exercise physiologist. And if those things aren't working, trialing medications if needed. Depending on what your major concern is how we will navigate your treatment plan. So if it's the irregular bleeding, then the combined oral contraceptive pill kind of will give you that regular withdrawal bleed if that's a concern to you. It also reduces the risk of endometrial cancer, which we know is raised with polycystic ovarian syndrome. For the patients who don't want the hormonal option, metformin is the second choice for irregular periods. So it can restore cycle regularity and ovulation as well. For some people we know with PCOS, they don't ovulate. Although they release all these follicles, they don't release that mature egg and ovulate. And it's often a preference for patients who are wanting to try to conceive and can't be on the combined oral contraceptive pill. So if your other concern is kind of weight, then metformin again is first line, and that can also improve the insulin resistance as well. And as I mentioned, it restores that cycle regularity in ovulation. The second line is these new GLP-1 receptor agonists, which are very, very helpful in these situations. The third line is, which I'm sure you've heard a lot of online, is the inositol supplements. So they essentially act as insulin sensitizers, and they're thought to promote the glucose uptake. There was a large study released last year which didn't really show much evidence for them, but if the patient is wishing to commence this medication, it's always a discussion with your doctor. You've got to talk about benefits, harms, obviously cost, and we know that with supplements they're not regulated like prescribed medications are. So,
well, can we talk about that? Because I've been seeing a ton of natural treatments on my social media feeds for PCOS. Like, there's lots of different supplements. Are there any that are actually proven to help with any of the symptoms of PCOS?
So inositol is probably the only one with a little bit of evidence for.
Yeah.
A lot of supplements can react differently with people, especially if they're on other medications. There can be interactions. And so it's always important to speak to a pharmacist or a doctor just to make sure that you're safe to use it.
We are going to be speaking to Professor Helena Teede more about PCOS in a tick. And we're also going to be having another quick consult where we can ask you, Mariam, like anything that we really are looking for an answer for. And Brianna has reached out because she's upset she wasn't told that a medication to stop pregnancy might not work for her. So as mentioned, Professor Helena Teede is going to give us the very latest on PCOS diagnosis and treatment next, and she's going to answer a dilemma that many PCOS sufferers are having right now, and that is, should I start taking weight loss injectables to help my condition? If there is one major update in the world of PCOS of late, it is the impact of weight loss drugs or GLP-1 agonists on the condition. Helena Teede is a professor of women's health at Monash University and is a world leader in PCOS. She actually has been leading the international PCOS guidelines. She says that the drugs do work and can help with PCOS, but there are many things that anyone who takes them need to consider. Helena, we talk about PCOS all the time like it's a pelvic problem, but it is a hell of a lot more than that, right?
Absolutely, Claire. So one of the problems is that this was historically first discovered when they noticed that there was what was thought to be cysts, and they're not cysts. They're actually eggs that are partly developed in the ovary. They don't like the hormonal environment they're sitting in. So they literally just go to sleep and they don't ovulate, which limits fertility. But when they sit there, they start producing a whole lot of hormones, which are chemical messages that go around our body and have very significant diverse impacts. And the problem is, because it was first seen when we saw these little bumps on the ovary, that's what it's been described as an ovary or pelvic condition. It's actually genetic, and we know there's a male version of it. It is very much environmental. As we become less active and as our food supplies become incredibly ultra-processed, that combination actually drives the condition as well. So it's genetic and environmental, and together those factors actually have made this more prevalent. And we know it has psychological implications, it has skin and hair implications, which are very visible. It has metabolic, so heart and diabetes, and it has reproductive. So not just infertility, which is what we all think of, but actually irregular cycles, very significant risks in pregnancy, and increased risk of endometrial cancer.
I wanted to talk to you about something that has been hitting my social media feed quite a bit in relation to PCOS, and that is the role of weight loss injections as a treatment for PCOS or semaglutide. How much do we know about the impact of these GLP-1 agonists on PCOS, and is it becoming part of the treatment process?
Yeah, big breath, big question. So one of the things that we do know, if I can go back a step, is that if we are of a higher weight, and I'm talking outside the healthy weight range, So if you're of a higher weight category where you carry a lot of adiposity or fat, so we know that people can be quite muscly and strong, and may fit in all the controversy about the body mass index or BMI categories. But the reality is it's a reasonable marker for how much body fat we carry around. As we carry a bit more, and we've got to move away from the concept of if you carry more body weight, it's your fault. You just need to change your behaviour. You need to eat less and move more. My grandparents, almost no one was overweight. Your grandparents, we know 2 generations ago, they were not more disciplined than us. They didn't have better behavioural strategies than us. They just weren't drowning in what we're drowning in. So 70% of Australians, including an increased percentage of young women, have higher body fat that is outside the healthy weight range. It is not their fault, and just simple behavioural strategies for the individual is not going to fix it. So just to put that down there as lay down there. For people with PCOS, they are more at risk of gaining weight. We know that. But it doesn't cause obesity, because what we do know is that when you can keep your lifestyle as healthy as you can, so forget about what your starting weight is or what your starting BMI is, the healthier you can be, the more health benefit it has. Exactly the same as if you have diabetes or if you have heart disease. So the role of lifestyle in managing PCOS is not to hang it over your head like a big dark cloud and say, whatever your weight is now, you've failed, you just need to sort yourself out. And actually say, whatever it is now is a product of the environment and the lack of prevention policy and dealing with big food that we have in our community. So the lifestyle role is to say, we're going to make you as healthy as we can make you, as active as we can help you to be, and to eat as well as you can. And my biggest aim with lifestyle is to try and prevent weight gain and to try and make as much of that muscle and a little bit less adiposity if I can, because that will have health benefits. That's unequivocal. But with lifestyle alone, if you have a higher starting weight, if you're in that very unhealthy weight range, just looking at lifestyle is completely unfair and unrealistic to give people as a challenge. So if you're in that higher unhealthy weight range, 1 in 1,500 people will manage to use lifestyle alone to get them back into the healthy weight range. Because every time we drop our weight, all of our lovely hormones that are predisposed to keep us alive for generations of evolution fight very hard to get us back to whatever weight we were. So if you start at 100 kilos and you lose 20 with incredible behavioural restraint and pushing against the environment we're in, you will have this massive rush of defensive hormones which will push you back up again. So even if you continue to eat less, it will just push you back. So our biggest challenge as a society is preventing people getting there in the first place, because your highest weight is always then your threshold. But we also then need to recognise that lifestyle alone is not going to fix this. So when we get to that point, we need to say lifestyle is critical, and it's there to make you as healthy as you can be, and we're just here to help you do that. Not lifestyle is the answer to weight loss, and if you don't do it, you've failed, because that's just unfair. Having said that, on top of that lifestyle to make you as healthy as you can be, for some women who have health implications because of their weight, which includes PCOS, it includes, unfortunately, fertility issues. And we know that weight independently quite significantly affects our fertility. PCOS significantly affects our fertility. Our age and our biological clock all significantly affect our fertility. And they all affect our health in pregnancy for the mum and the baby. The solution is not to blame the woman who's in this toxic, environmental context, but to be as helpful as we can to try and work through that. So lifestyle for whatever you can. But for some, we do know that using additional agents is going to be important, especially for things where you've got diabetes or infertility or additional complications. So that's where we've had, I suppose, a bit of a revolution with the injectable and now tablet forms of semaglutide. Tablet's not available yet, but it's well used overseas, and the newer agents that are coming out. They are exorbitantly expensive, and there's no question about it, and they have side effects. Most people on them don't feel particularly great. But the fact is they are very effective. And as a strong public health advocate, I hate to admit that, Claire, to be honest, but I do know that for people who have that established in that unhealthy weight range or very unhealthy weight range that have health implications, they have a role. So semaglutide is going to come off, since you mentioned it, it's going to come off patent in about 2 years. We are going to see things change very quickly once it becomes incredibly affordable. So knowing that that's coming. What we have in terms of evidence about these agents is that we know they usually result in about 15% weight loss. Some of the newer agents, 20 to 25. Not everyone responds to them, but if they do, that's the sort of degree of weight loss we're talking about. They make people feel unwell. They get nauseated, they get full because they work by slowing the absorption of food in the stomach, and that really affects your appetite. But you just walk around being very full, bloated, nauseated, vomiting. They can have change in their bowel habit. And a lot of people don't feel that great. And long term, that is significant. But in terms of other significant, really high-risk side effects, there are not that many. There's a very small risk of others, but people don't necessarily feel well, and it costs a lot of money. What we do know, though, is based on general population data, they work. But you have to keep taking them, see what the cost and the side effects long term. In PCOS, there are only a couple of studies, and unfortunately there's a few that have not yet been published, but I've seen the results and they will be published shortly, including a big trial in adolescents. They work. They just make people often feel a bit miserable because they're nauseated, vomiting, full tummy, and so sustaining them long term is a challenge. But the biggest issue is once you take them away, and they're just hormonal chemical messenger treatments, once you take them away, almost everybody regains the weight, just like they do when they stop their lifestyle or any dietary or intervention, when you stop it, you regain it. What we don't know, and this is partly because the nature of our research, which is funded often by pharmaceutical companies, is we don't know what the best strategy is for when you come off, because the drug company's not interested about when you come off. They want you to stay on the medication. So we know it has significant effects in terms of benefit, but we also know in PCOS, one, people don't necessarily want to continue it, which is everywhere, but especially in PCOS, and I'll talk about why. And then two, when you do stop it, how do you maintain or abate that very significant rise that we all get, not because of personal failure, but because of the environment that we're living in? So those are the two really big questions. The other thing that's different for PCOS is these are reproductive age women mostly, but we have it through our lifespan. But if it's reproductive age women, which means they may want to conceive. And we do not know if these drugs are healthy or safe in pregnancy. Even at the time that you conceive, we don't know. Hormones often cross the placenta. What does that do to the baby? So that's not known. So we tend to stop them when people are thinking about getting pregnant, not when people do get pregnant, but when they're thinking about getting pregnant. The other problem, though, is that many people get pregnant when they're on them, and we don't know what the safety is. The other problem is when you stop them in pregnancy, the weight goes up dramatically through pregnancy. And we know that independent of PCOS and age, both of which already impact a mother's health and a baby's health during pregnancy, if you have a high rate of weight gain during pregnancy, there are a lot more complications for mother and baby. So it doesn't matter what weight you go into pregnancy at, whether it's high or low, that has an impact on risk. But independent of that, what you gain in pregnancy, if it's too low or too high, is really not great for mother or baby. When you come off these agents and you get pregnant, we're seeing mums put on 30 kilos in a pregnancy, where they should have been putting on between 10 and 12 or even a little less than that. And they are putting on massive amounts of weight during the pregnancy because they've just stopped these agents. So the complex answer to your question is reframe the way we think about weight and the personal blame and stigma that comes with all of that so that we can help women understand that. Then use lifestyle to keep them as healthy as they can be, and maybe just little marginal amounts of weight loss. They can, up to 5%. For anything more than that, we're going to need treatments. The treatments that are available work, but they come with side effects. They're not appropriate in pregnancy, and we've really got to help and support women when they come off them and go into pregnancy. And the final thing, though, is that metabolic or bariatric surgery is a lot better than it used to be. With these new injectable agents, everyone's going, we don't need that anymore, we'll do this. The reality is that those surgical procedures last 20 years or more now. Yes, they have side effects, but they are really effective and they're a one-off cost. And what we do know from a recent very good trial in PCOS is that women with PCOS can almost resolve many of their symptoms and features if they have metabolic surgery and drop their weight. So I think knowing that you can't quite cure it, but you can dramatically improve it. And then if they get pregnant, they need extra support during pregnancy for nutrition. But for many women with PCOS, that sort of question about, do I use injections or agents, or do I use metabolic or bariatric surgery, there's probably a bit more of a pendulum switch towards surgery as a reasonable consideration. For a woman who's really struggled and has quite an unhealthy weight, it will give them major long-term benefits. So long answer, but complex question.
What does the research tell us about PCOS in 2025? We are seeing more money being invested into these areas of women's health. Are we seeing any major breakthroughs in either finding causation for PCOS treatment? Where are we at in 2025?
Yeah, so the biggest evolution over the last 10 years is understanding the role of lifestyle and, addressing the stigma. It's understanding the new tests. So AMH, for example, that ovary-related test was only recommended in the 2023 guidelines. So the evidence has come out around that. In terms of treatments, the things that we really do understand that are very effective, simple laser therapy, cosmetic therapy that you can get at your, local mall laser place does work. And actually can permanently reduce hair. And that's something that has not necessarily been appreciated, but at the moment it's not subsidised. It's a medical condition, and that treatment should be subsidised. It has devastating impacts for young women. They get really major self-esteem and body image issues. There's 8 times the suicide rate in PCOS over women who don't have PCOS. It has more of an impact on your quality of life than diabetes. It has an 80% prevalence of depression and anxiety symptoms. And a lot of it's because the other features are not treated well. So knowing that you can treat these features, we need to do things much better. In terms of other treatments, there is quite some exciting work looking at the brain hormones that actually drive some of this, and a lot more understanding about the different subtypes of PCOS, like lean women who have PCOS, and the effects of ethnicity. So in the next couple of years, we will get a much clearer understanding of the subtypes, and women will then know what their long-term outcomes, not just one size fits all, what their long-term outcomes are likely to be. We'll get better insight into which treatments are better suited to which types, and that will make a big difference in terms of the way we approach it. We'll also probably get new treatments that are available, but they'll be a little while off because treatment development takes a while. But I think one of the biggest things we need to do better is rename the condition. So we now have 8,000 people from around the world, health professionals and women, over many years who we've surveyed and worked with, and 91% of them want to change the name. So we are currently leading an initiative at the moment, which should culminate around the middle of this year, to change the name and to recognise that it is much broader, and then very much lobbying to make sure it's appreciated in diabetes guidelines, heart disease guidelines, and in undergraduate education for all health professionals, so that women are not stuck in the paradigm of this is an ovary condition in the pelvis, which it clearly isn't. So they're the sorts of trends that we need to do, work much more closely with women who have the condition lifelong to support them. And I'll put one plug in if I can, Claire, which is of the guideline work that we've done, and we lead the international guidelines, and it's been a big journey, a big body of work. They're actually they're used in 195 countries, and they're the only guideline ever that will be adopted by the UK guideline group. But with them, one of the things we did was we worked with our consumers and patients from around the world to develop a free app. It's purely free. There is no advertising. There is no influence. It's called Ask PCOS. That's used in 195 countries too, and it's been accessed by more than 1 million women. But it's evidence-based and it's personalised, and it's about to contain what we call shared decision or patient decision aids. So even the question of, do I want to know if I've got a diagnosis of PCOS? Because often doctors think, she's a young girl, we don't want to distress her. Maybe we won't tell her, we'll just treat her. And the whole concept of knowing someone has something that has lifelong implications with prevention opportunities and not telling you is just inappropriate. So there's a decision pathway that they go through. What treatments might I look at for my hair growth? What treatments are available for preventing diabetes or what have you? And it takes them through the decisions they would make and why they would choose one over the other. What do I do about weight challenges? Why would I choose lifestyle? Why would I choose the injections? Why would I choose the surgery? And where do I get my advice? It's currently in about 15 languages, but soon will be a lot more. And the reason we're very passionate about it is that it gives women evidence-based information instead of misinformation. There is no miracle diet, the lemon diet, the exclusion diet, the restriction diets, they don't work. So it gives you evidence-based information, and it gives you all these tools to take to your health professional, to almost educate them with you as you go on the journey, as you make decisions about your health. And I think for me, in the next few years, that's going to be the most important thing, is getting the community, women and health professionals to understand the condition and use the treatments that are available.
Just one last thing. If you didn't have to ask anyone and you didn't have to figure out a consensus amongst all of you, what would you rename it to?
I personally would rename it to reproductive metabolic syndrome, and that's because that has mainly come from the women who have the condition. A lot of them also quite like the term endocrine, which is related to hormones. They do not want, and believe me, some of the medical ones that have come out have been quite horrific, like they want obesity in there, they want androgens, they want hormones, imbalance. All of those things did not work for the vast majority of women. They might be technically correct, but that's not appropriate. So for me, it would probably be reproductive metabolic syndrome, but the most important thing here is not exactly what it will be, but the process we're undertaking to get it there.
A really big thank you to Professor Helena Teede for sharing her expertise with us. She is a world leader in this space, so it's really amazing that she sat down with us to talk about it today. But this is for all the people who do not have PCOS and who probably had not a great grasp of what exactly it is up until this point, because we all just presumed it cysts on your ovaries.
Yeah, it's such a misleading name. It's definitely not a condition of the ovaries. It affects your entire body system. So yeah, it's a very misleading name.
Okay, coming up next, it is quick consult time. And today, Brianna has reached out to us. She's really upset because she took a medication. It didn't work. She then Googled and found out why.
The doctor will see you now, just through here to consult room 1.
Thank you for waiting. How can I help you?
Love it. This obviously is where you can ask Dr. Mariam any of your health concerns, and we'll do our best to answer them with the most up-to-date information that we have. If you want to ask a question, send us an email, well@mamamia.com.au, or leave us a voice note. You can figure out how to do that. There is a link in our show notes. Brianna sent this in via email last week, and it is something that everyone who's ever been concerned that they may have been impregnated but do not want to be might have felt. She wrote this.
I recently took the morning after pill after a one-night stand where a condom didn't do its job particularly well. I've now found out that it didn't work, and when I went to my GP, she said that it was probably because of my weight. I looked it up, and apparently the morning after pill is less effective if you weigh over 70 kilos. Why didn't I know this? And what options do we have if we're over that? Someone told me if you get an IUD in within 5 days, that will work.
So that is something I did not know, and I have taken the morning after pill before, and I've definitely been over 70 kilos. But, is that true, and is it also true about the IUD?
So the copper IUD is the most effective morning after contraception.
So that's real?
Yeah, that is real, but it's the copper IUD, not the hormonal one.
Gotcha.
And that can be inserted up to 5 days from the unprotected sexual activity. But generally we recommend getting a pregnancy test 3 weeks after insertion. There are a lot of contraindications to getting the copper IUD, so it's really important you book in, see a doctor and see whether or not that's the right option for you.
That also makes it difficult for women who live in regional or remote areas, because you've got such a limited time window that booking into your GP sometimes, even for the most basic of things, is really difficult.
That is tough.
Out of metro.
Which is why the tablet approach is a lot easier for many patients. You just see your pharmacist and you get it over the counter. So when you see your pharmacist, they should be asking you lots of questions, and that's generally around your weight, so don't be offended. And they should be asking whether you're on medication. And the reason being, some liver enzyme medications can reduce the effectiveness of these pills. And interestingly, also, if you take these pills, because they can cause nausea and vomiting, if you vomit within 3 hours, you need to take them again. And the weight for each of these medications is different. So one is above 70 kilos, it reduces its effectiveness. And the other one is 85 kilograms. So each of those medications have kind of different criterias in terms of what your weight needs to be. So your pharmacist should be having this conversation with you. But it's important to know this, because if that pharmacist hasn't had that conversation with you, there might be a possibility of pregnancy.
I tell you what, nothing puts the fear of God into you more than when you're in that window of not knowing whether you're pregnant or not, if you don't want to be pregnant, because like it is seriously just all you can do is sit there when the pregnancy test is too early to work. You just have to sit there and wait.
My husband will be away for work for weeks and like I haven't had sex, but I'm like, am I pregnant?
Why? Why do we do that to ourselves?
It's just like this intense fear.
Thank you very much for sharing that with us, Brianna. And of course, if you have one of those that you want to share with us, send us an email, well@mamamia.com.au. Thank you for joining us again on Well. If you have any questions about what we've discussed or any health concerns that you want us to look into, again, hit us up on that email or leave us a voice note. And if you're interested in having more health-related content in your inbox, sign up to the Well newsletter. There is a link to do that in the show notes. And as always, the advice you've heard here today is general and may not suit your exact needs. So make sure that you reach out to your own doctor or healthcare specialist. They will have the info that is 100% right for you. And we'll see you for your appointment here again this time next week.
Thank you and see you next week.